Hey everyone, welcome to the May episode of Health Equity Mondays. You're joined by Jasmine and Omari, and today we're going to talk about the latest astronomical dollar amount spent because of health disparities in this country, and also the FDA creating more equitable restrictions for blood donations. Hey, welcome to Health Equity Mondays, hosted by Jasmine Leonard
and Omari Richins. Here we'll talk about all things health equity, public health, and culture.
Let's do our part to move health equity forward and all that jazz. So, Omari, how are you doing?
I'm doing okay, chugging along, doing all the things, trying not to get overwhelmed or stressed and taking time to really focus on myself. We'll be taking a trip to Asheville this weekend. I'm going to enjoy that. But that still puts me back on not doing some of this stuff that I'm trying to do, but redoing my website. So by the time you'll hear this, go check out my website, thephmillennial.com, and you'll see like a new layout, some fresh new, not really branding, but just like changing of language and our social context. So look out for that. But I'm doing well, just doing all the things right now. How are you doing?
Surviving the last week of my first year of my DRPH program. It's wild to think that it's been a full year, and because I have tried, or I'm trying to get done in 4 years, I essentially get a 1-week break and then I'm right back in classes. So yeah.
And we love that class hustle. Hey, someone's got to do it. So shout out to you. And yeah, the years definitely fly by, and you're gonna get it done in 4 years. So 3 more years to go.
Yeah, that's the plan.
Good to hear.
So for our first discussion item, last night I was looking on LinkedIn, and Deloitte, they put out all these interesting articles about the cost of health disparities. And they linked to a new article that was put out, I want to say yesterday, not yesterday, May 16th, the National Institute on Minority Health and Health Disparities, they put out an article. It's unfortunately behind a paywall in JAMA, the Journal of American Medical Association, but
give us health equity.
Okay, we're talking about health disparities and then you put it behind a paywall, but it's fine, all right? So they basically said that the last time that we spoke, and I think we talked about this in our very first episode about the cost of health disparities in the United States. I think we said that it was like 300 billion or something like that, something ridiculous. They basically said that that number is wrong and it costs even more. And so I want to tell you all the findings because I think it's very interesting in terms of how they laid this out. But the big takeaway is in 2018, the economic burden of health inequities for racial and ethnic minority populations was 421 billion with a B.
With a B. Wow.
Billion or 451 billion. So they looked at this in two different ways. But basically, it's a lot of money. And that's the burden for racial and ethnic minorities. They went a step forward and said, what about education? Because if we remember the social determinants of health, educational attainment is a part of the social determinants of health. Health inequities for adults without a 4-year college degree was 940 billion or $978 billion. I'm going to just let that sink in.
That's almost a trillion, if I'm correct with my numbers.
You are absolutely correct. That is almost $1 trillion for not getting a college degree. And then $500 billion if you just consider race. So, yeah.
That's alarming, yeah.
It's really alarming. But then this further alarmed me when it says most of the economic burden was attributable to the poor health of the Black population. Okay, it does say that, however, the burden attributable to American Indian or Alaska Native and Native Hawaiian or other Pacific Islander populations was disproportionately greater than their share of the population. But they basically said because of the Black population, that's where a lot of this economic burden comes from. There is a lot of information in this article, and I'm going to pull it up just for a second because there were a few things that I think are important to highlight, especially how they get the data and how they define health equity, because we all have very different definitions.
Right. And I feel like that's always something that's important that we have to think about when we're having these conversations. Like, what are the definitions of the terms that we're talking about? But those are astronomical numbers that we're talking about. I think it just goes to show the case why we need to work towards improving health inequities, because it helps us all as a society to just have a better society and less debt, less stress, less money worries. But it would be interesting to see and learn more about what the attributable factors to this great burden of billions of dollars looks like. But Jasmine's got the article up.
When we look at their definition of health equity, they define it by targets of reaching the 10th percentile of the predicted prevalence rates for 13 health conditions. This is very statistical. The 13 health conditions are some of the top ones that you would think about, like hypertension, high cholesterol, diabetes, coronary heart disease, heart attacks, so on and so forth. Basically, all of the conditions that we highlight when we're looking at health disparities, right? So they say that you need to reach the 10th percentile, meaning that you fare better than 90% of the population in terms of the prevalence rate for these diseases. Okay. So they also look at 4 databases. I won't go into the details about that because it's a lot of stats, but the results are still astounding. In overall economic burden of failing to achieve health equity goals, it was $1.03 trillion. Okay, so as a country, your tax dollars, your salary, all of that in 1 year, because we are an inequitable society, it cost us $1.03 trillion. I don't know about y'all, but that's money that I can't even fathom. I don't even know how many zeros. How many zeros is that? Right? Like,
It's a lot. It's a lot. I
it's
think
a
as
lot.
21 Savage would say, it's a lot. But that I think this is important to highlight, and just like this link, because this is not something that we talk enough about, like the economics of the health burden. And because I think that's an important factor when you're thinking about making these big policy decisions and thinking about how can we decrease these health inequities, understanding that there is a financial bonus or like addition that you get from improving health and addressing the people that are most disproportionately affected by a lot of these diseases and conditions, and essentially like social determinants of health that lead them into these ways of things. So like, how do we address that? And I think putting that number on it is something that public health doesn't always do too much, like a lot more on the policy side. But I think everyone needs to find out how can we measure what kind of like monetary impact this would have, and be able to link that to different outcomes and different ways that we're instilling different like programs and systems.
Absolutely, because, and I posted about this last night, right? Like, even if you don't care about health equity or you're kind of over it being a buzzword, there's an economic imperative for us to address public health issues and disparities. Because, I mean, if anybody is paying attention right now, where the country is concerned about whether we're going to extend the debt ceiling or not, like, we don't have money to be playing around with, and 1.03 trillion is not money to be playing around with. I mean, I don't know, you'd have to fact check me, but like, isn't that how much the like military gets per year or something? Like, it's a ridiculous amount of money. Two other points that this article makes is that, again, I know we focused in at first about the racial and ethnic minorities, so that $400-ish billion. The white population is responsible for the rest, so like $608.7 billion. And the unfortunate part of this is that for racial and ethnic minorities, most of their burden is due to premature death, approximately 2/3, while excess medical care costs was 18% and total cost and lost labor market productivity was 14%. So again, even those industries that are tangential to public health, there is a financial imperative for you to actually care about the health and well-being of your population because they are costing money. The last thing that I'll say about this, when I said that most of the economic burden is based on the Black population, 74%. Remember back when we were talking about the Black population only being about 13% of the population? When we look at the economic burden, 74%.
That's very disproportional to me.
Right? It's it's not good. Unfortunately, like I said, this full article is back behind a paywall. But if anyone's interested, I don't care about paywalls. I will download it and send it to you. So if you email me, I'll send it to you. But
What's your email?
Jasmine at healthequityjazz.com.
Okay, send all the emails there. Send her questions about the show as well.
Yes. Send me feedback.
Yeah,
Are you astonished
yeah.
by this number? Because whew,
And it's important just to understand that this only doesn't affect Black people, while disproportionately does affect them and cause more of the burden. If we're able to improve health overall, it's going to have an impact. But just understanding that you're going to get more leverage for your dollars when you improve the lives and the health of the people that are most disproportionately affected by the issues. So I'm glad that you raised this up, and this is definitely something that we hope people are talking more about and linking more about what are the financial and economic burdens of not implementing certain policies, and understanding like what that really costs us as a society, not only health wise but economic wise, because I think that's also an important driver, especially when you're thinking about living in the capitalistic United States of America.
I mean, dollars matter here, right?
Absolutely. Absolutely. And you know what else matters? Hitting that subscribe button so that you can stay up to date with the great content on public health careers and Health Equity Mondays. And be sure to follow us on Instagram at the PH Millennial and Jasmine at Health Equity Jazz. That's on Instagram. And but I know that Jasmine has a couple other things that she wanted to share. Before I pass on the mic, if you enjoy the Public Health Millennial, if you enjoy Health Equity Mondays, if you enjoy Public Health Careers podcast, and you've gotten some value from the show, just be sure to check out that link below to support at Coffee or Ko-fi or KO-FI, however you say it, and you become a monthly supporter or a one-time supporter. It really helps the show, really helps me grow this platform, helps me to purchase a new laptop that's hopefully coming soon. So definitely check out that link. I appreciate you all, and I'll pass it on to Jasmine.
Yes. So if you like what I bring up and talk about, please follow me at Health Equity Jazz on Instagram, also on LinkedIn. And you can also subscribe to my newsletter. The link is below. I talk about my DRPH journey. I talk about kind of the mental health of figuring out how to be an employee and a student. And I discuss, things like this that I bring up on the podcast. So if you like that, subscribe. And I do have a paid version of my newsletter that is more about the Jasmine behind Health Equity Jazz. So I talk about vacation. I'm probably going to share lots of photos because I am going on vacation. And I talk about the future motherhood journey that I'm on and all the things. So subscribe to my newsletter if you're interested, pay a little bit, and you can learn a lot more about me.
And all links are below to articles and to different things that we share, and all the ways that you can support us, as well as go check out my website. This is accountability to have it finished by the time this episode is out. So be sure to check it out. Maybe sign up for my email list if you have not as yet, or just let me know what you think about the website. Greatly appreciate you all. So moving on to the next article that we're going to talk about, and this is around the FDA relaxing restrictions on blood donations. So before I share the article, like why does this matter? Blood donations are a fundamental part of the society that we live in, especially when there are so many accidents and injuries that happen just day to day in society. 1 in 7 patients entering a hospital will need a blood transfusion. 1 in 7. That's pretty crazy. I did not know that was the stat beforehand, and that's kind of terrifying to know that 1 in 7 people,
One
and
in
as well as
seven?
right, 1 in 7. That's very frequent. I
Wow.
know. So every 2 seconds, someone in the U.S. needs blood and or platelets, and this can be from accidents or having to like have cancer treatments or just a whole host of different reasons for what people needed blood transfusions. And according to the American Red Cross, who supplies 40% of the blood donations across the US, there's a blood shortage in the US. They declared the first ever blood crisis in January of 2022, and the problem still extends to today. To meet the shortage needs of the American Red Cross estimates that there's a need of 12,500 blood and nearly 3,000 platelet donations every single day. And there's been a huge shortage when it comes to these specific types of blood, which you can check on their website. So this is very, very fascinating. And then when you extend it to the conversation that I kind of want to get into is prior to this FDA relaxing on the restrictions, men who had sex with men and women who had sex with men who had sex with men will automatically turn down from giving blood. So I'm going to pull up the article here.
So while you're pulling that up, do you donate blood?
It has been a while since I've donated blood, if I'm being honest, in all honesty, but I didn't realize that it was such a huge need. So I might try to go and donate blood as soon as I can.
Yeah, it's been a while for me too, but I have O positive blood, so I know I'm one of the people that they want to donate. So I need to go do my job. So if you're out
Right.
there listening, if you have O blood, you're kind of like saviors in ways. So go donate, please, if you can.
Right. I was looking up, and that is the blood type that hospitals need the most. And we'll definitely put a link below to whether we can like probably a site where you can find blood donation places so you can go donate blood. So talking to the article here, the article is on the FDA's website. So the FDA finalizes a move to recommend individual risk assessment to determine eligibility for blood donations. So you can see this article was released on May 11th of 2023, and it goes as starting by today, the U.S. Food and Drug Administration, or the FDA, finalized recommendations for assessing blood donor eligibility using a set of individual risk-based questions to reduce the risk of transfusion-transmitted HIV. These questions will be the same for every donor, regardless of sexual orientation, sex, or gender. And I think that's the big part that has changed there because, as I stated earlier, people were turned away just because of how they identified as. But now this individual risk assessment is going to take that. It's going to still take the risk factors into consideration, but in a less stigmatizing way. So this updated policy is based on the best available scientific evidence. We love to see policies implemented that have some evidence behind
Hmm.
them, and it also has been done already in places like the United Kingdom and Canada. So in a
Who would have
statement
thought?
by the right, right. So, in a statement by the FDA's Center for Biologics Evaluation and Research, the director, Peter Marks, he said, quote, the FDA has worked diligently to evaluate our policies and ensure we had the scientific evidence to support individual risk assessment for donor eligibility while maintaining appropriate safeguards to protect recipients of the blood products. The implementation of these recommendations will represent a significant milestone for the agency and the LGBTQI plus community. End quote. So essentially, this policy eliminates time based deferrals and screening questions specific to men who have sex with men and women who have sex with men who have sex with men. Under the final guidance issued today, all prospective blood donors will answer serious individualized risk based questions to determine eligibility and really taking that step away from just creating barriers from people that are people who were men who had sex with men or women who had sex with MSMs. And this is a good step in reducing the stigma. It is so important that we not like just point out one group and say that they're not able to take part in this for no particular reason, but now taking this approach where they have an individualized risk factors that they are assessing with every single person. This is helpful in taking those first steps to reducing stigma and discrimination, and I think it will be very helpful over time. And as I stated above, there's a critical shortage of blood supply. So, like, the more people that are able to donate blood, I think the better. What was interesting for this, because I thought people who have HIV who were on PrEP would still be able to give blood. But I learned today, and you're learning today, that this is not fine, because people who have HIV who take PrEP, which is pre exposure prophylaxis, which essentially reduces the viral load of HIV in your blood to the point where you can have sexual encounters with people and not transmit HIV. So I thought this group of people would still be able to donate blood. However, this is not the case. While PrEP is useful for reducing viral levels in sexual contact, and it is not transferred to the other individual, but this does not apply for intravenous drug and large volumes of blood compared to sexual contact. Thus, this is one of the questions that they ask, and if you say yes to it, then you are not able to donate blood. So that was interesting to learn, and but I think this is a good step and a great step in the way to reducing stigma around HIV, reducing stigma around blood donations, as well as I hope that there's a way to get something where PrEP is able to reduce that viral load so much that you're still able to donate blood and not transmit HIV to the person that you are donating to. So interesting stuff. Good steps forward, I would say, from the FDA. So shout out to them, and hopefully we can keep on making some progress on this.
Yes, I'm happy to see this because honestly, I always thought it was stupid that this was actually still in the books as like a reason for not being able to donate, especially when you're assuming that people know who they have sex with and who their other partners are. So if we
And you're
know
essentially
anything,
right, and you're essentially assuming that men who have sex with men or women who have sex with MSMs have HIV just inherently, which I think is a bad assumption and just leads to the bigger issue of the stigma around HIV, around testing, around all these different sexual health issues and topics.
yeah, and it's one of those things where honestly, if we know anything about HIV, at least here in the United States, the heterosexual population has the predominant rates of HIV. So are we also doing the same and holding blood and thinking that every person that walks in that has sexual partners and more than one, more than two, whatever the case may be, that they also have HIV or some risk for HIV, especially depending on where they're from, given the rates that are within certain cities. So I'm happy to see this. I'm waiting for it to extend to sperm donation because that is also a place where men who have sex with men are unable to donate. So let's go.
More to come.
Is it quiz time?
Yep, quiz time.
Oh.
Stretch for this one.
Why are you stretching? Do you think you have? I
It's
think
just
you might get this one.
I hope so.
All right, it is equity in action time. It's my turn to
Whoop,
ask
whoop.
the question. If you have been following along, you know Amari is struggling. I had to give him a point for his birthday month, and it's just been a struggle. So,
Soon I might have to call someone in the crowd to come and help me. So be on the lookout for that.
right,
Lifeline.
phone a friend. That might help. You might be onto something. We'll see about that. So, Omari, this one is I'm asking this in honor of Memorial Day, which is when this episode is going to air. So it's about Black veterans, okay? Are you
Okay.
ready? You got it?
We'll we'll see.
All right. True or false? Black veterans have a better quality of life than Black non-veterans.
Ooh, that's that's a tough one. That's a tough one because you have the social safety net of the VA hospitals there, which I think a lot of Black people just generally don't have that social safety net. So I would say they generally have a better quality of life.
You got it.
Oh yeah.
What? All right. So, we like to actually give you information. So let me pull this up. I'm happy for you, generally.
I've been working out. I've been working out my brain on these quiz questions. So it's about time. It's about time.
So Omari got it right. Black veterans generally have a better quality of life than Black non-veterans, but still struggle compared to white Americans. So this was a news release by RAND that came out in November of 2022. And essentially they did a study, and it says that they were looking at the association between military service and the physical health, behavioral health, economic stability, and interpersonal relationships of Black Americans. And it showed that Black veterans still struggle to achieve economic parity with white Americans, regardless of military service. So there's some racial disparities, which we're not surprised by, but there is a positive side to Black veterans, and what Omari was speaking to, the social safety nets, and they also have higher incomes, higher rates of home ownership, less reliance on food assistance, and then the interesting things of marriage in this country and our fascination with it. But Black veterans are also more likely to be married and at younger ages, which generally corresponds to a better quality of life. So, Omari, you got it right.
Yeah, awesome. That's good to hear. And I didn't even think about the higher rates of home ownership, but like veterans have like 0% down home loans and a lot
Yep.
of other benefits that typical civilians don't get. But yeah, I'm glad that I was able to get this one correct today, and I think that was a good one. So thank you for sharing that. Some good information, and hopefully we can all push for more health equity and more and better health, more safety nets, and more policies and systems to support people that need them, veteran or not.
Yes. So before we end, I have to give a couple of shout outs because it is Memorial Day. So my dad was a veteran and my maternal grandfather. So they're no longer here with me, but I carry their flags every day. And um, special shout out to my health equity intern at work. She is graduating. So she'll graduate June 15th, Ariana Simpson. This shout out is for you. Thank you so much for being an amazing intern. I loved having you, and I'm so excited to see what you do. She's graduating from Drexel with MPH and epidemiology. So, y'all, if you're listening to this and you're an employer, she is looking for a job after she comes back from Europe. And yeah, I just want to give her a special shout out because she did an amazing job.
A shout out to you, Ariana, and enjoy your Europe trip. Be safe. Thank you all for tuning in. Thank you all for supporting us. Be sure to subscribe. Any last words, Jasmine?
Happy May, happy June that's coming, and I hope that you're back next month.
Yeah, be sure to be back next one and share it with someone so they can come and listen to us as well.
Yes. Bye.